the newsletter topic onwards.
Okay, Nupur, go ahead. Or we can wait for another 5 minutes so that more and more people can join.
Yeah, I don't see anyone joined except Dr. Yasmin. So we will just remind in the group.
So we will start sharp 9.
We have to remind, I think, in the group for everyone to join.
Yes, yes, Nupur.
Okay.
Screen is visible to us.
So I think we have already we are at 9 o'clock, 9 a.m. And I see a couple of doctors have joined. So good morning, everyone. This is our very first monthly meeting of Cardiopcon Society, where we are going to discuss a few important topics, and we want everyone to provide their suggestions for the topics which we will be discussing. And there will be chat which will be where you can actually input your details, give your inputs about the topic or suggestions. So a warm welcome to everyone for this meeting, and I am going to start, and then I will hand over it to Dr. Ashutosh and Dr. Pallavi to proceed further. So first, I would like to talk about what are the initiatives Cardiopcon Society is taking for this year. So we already have national level conference annually happening, and we just went through our 13th national conference focusing on cardio, diabetes, and renal care. We are also starting state chapters from next month onward. So we had been doing it, but for this year, we are starting from next month our state chapters. Then we are going to release monthly newsletter, and for that we want input from all the faculty members. We want active contribution from all of you, so we can come up with topics which are useful in the area of cardio, diabetes, and renal research. So we'll be discussing few suggested topic in coming slides. Apart from that, we are also working on conference proceedings book. So we had our annual conference where many of you presented. So we are collecting and we are consolidating the information. And if any of you have not yet sent your articles, please send it so we can include it in the book. And we will be planning to release it by next month end. Apart from this, we already announced that we will be working on clinical trial in cardio, diabetes, and renal area. So we had requested inputs from all of you, and we have already started working with a couple of leads here. So we would request you to suggest if you have anything in your mind. And then we are also working on increasing our presence on LinkedIn and Facebook so that we can reach out to more and more corporates and more people can benefit with our initiatives. Any questions? Okay. So the newsletter topic which we had got inputs are, there were 15 topics which are also I put for the poll, and out of this, if I go, there are few topics where we had got votes, like people are more inclined to those topics. So we will be in further slides, we will be discussing about those topics. And if there is any inputs, let us know. Let us know your point of view. What are benefits? What are drawbacks of them including in our newsletter? So from here onwards, I will hand over to Dr. Ashutosh. Dr. Ashutosh, over to you from next slide onwards.
Thank you, Nupur. So it is a very nice initiative from the Cardapcon Society, and I am very happy that the chairman and other members have decided to go virtually and interact the faculty members across the India to have their input regarding all different topics and the recent advancement which is happening throughout the last 3 to 4 months. And in this meeting, we are accommodating the clinically relevant topics which we have already listed in the group, and on the basis of votings we have selected few topics for the discussion, and in due course of time we will discuss all the topics which have maximum votes. And if you have any other suggestion or you want that some other topics would be included, just type it in the chat box or in the WhatsApp group. Due course of time, what my team will do, they will research the topic, they will found the reference, and they will draft, and your name will be included in this, and we will have a small abstract type of publication in the newsletter. And if you are having any interesting case report, or you come across any clinical finding which has to be validated, or you think that any trial which is important, and any important drawback or anything else, any limitation in the topic can be also addressed as a remark in the newsletter. So to start the discussion, let's come to the first topic, that is the recent evidence of diabetes in obesity and metabolism. So let me see how many of the faculty have joined it, and if anybody wants to say something regarding this, their opinion is welcome. What they have to do is just raise the hand so that Nupur will allow Nupur or my team, including the reserve and other people, will allow that person to speak. So the recent researches which has shown there is an interaction between the obesity and type 2 diabetes mellitus, highlighting their interaction. And we all know that diabetes is very important topic. And in this regard, we all know that because of the increased visceral adiposity, there is inflammation, fibrosis, and hypoxia, and there are disturbances in adipokine secretion, which will lead to mitochondrial dysfunction. And because of all these factors, there will be pancreatic beta cell dysfunction as well as increased atherosclerosis. In this regard, recently there are few development like metabolites like acetyl-CoA and palmitate. The ratio of these two uridine, it plays a significant role in influencing insulin sensitivity by modifying the post-translational modification. So this is a new finding which has come in recent past, and this needs to be addressed because we all know that acetyl-CoA enzyme is a very important molecule interconnecting the different metabolic pathway like the lipid metabolism, the carbohydrate metabolism, and the fat metabolism. And if this palmitate acetyl-CoA ratio is altered, the pathway can be driven either into the lipolysis or lipogenesis or into the gluconeogenesis pathway. So this is very, very important. And if the person is lean insulinopenic, then this ratio can also predispose that person to the production of more and more ketone body. And we all know that ketone body are now important alternative fuel in terms of reducing the inflammation. So certain amount of ketonemia can be protective to cardiac adverse side effect, as well as there can be nephroprotection also. So I will like to listen from you people that what is their view, your view regarding this thing, and should this metabolite can be used as one of the marker in the clinical study, and further research can be planned. So we are basically trying to include this topic in the newsletter so that the faculty members and other person will be sensitized regarding this new development. I will like to have opinion on this, opinion of the house. So may I have any person who wants to speak? Nupur, please see, is there any raised hand? Then allow them to speak. हमको म्यूट कर दे. Hello, am I audible? Hello.
Yes, yes, Dr. Ashutosh, you are audible.
So I am audible throughout, or it was mute?
No, you were audible.
Okay. So if anybody wants to speak or give any opinion regarding this topic like obesity and diabetes and the recent development like Acetylcholine and these new markers which can predict the obesity and its complication. If there is no opinion from the house, may I proceed to the next topic?
Yes, Dr. Ashutosh, and on the basis of voting, we can include the cases or the topics.
Okay. So coming to the next part, the next topic is the role of protein intake in the prevention and management of type 2 diabetes. So this is very, very important for us, as we all know that in India, the main problem with our Indian diet is it is mainly predominantly containing the glucose molecule, and 75% of our diet is composed of mainly carbohydrate. And the other previous trial has shown that reducing the glucose content in the diet will further improve the postprandial blood glucose excursion, and by reducing this postprandial blood glucose excursion, actually we can improve the lipid profile, we can reduce the complication, and we can reduce the progression of diabetes. So in this regard, increasing protein intake and emphasizing their role in our balanced diet is very, very important, and we can incorporate this topic in the newsletter, as it can give a good insight of the treatment, and in our day-to-day clinical practice we can emphasize on that, and we can counsel our patient regarding the intake of the protein. And what the recent development has taken place in this area, that increasing the protein intake will reduce the postprandial hyperglycemia, and it will increase the insulin sensitivity. And in long-term protein intake, the insulin resistance can also be reduced. And the protein intake guidelines according to American Diabetic Association is approximately 1 gram per kg, and we found that in most of our patients the protein intake is low. So even if we advise some increased protein intake in our patient, still we are not going to harm the patient. The upper limit of the protein intake in our cardio-diabetes patient is up to the 1.3 gram per kg per day, while in the renal patient we can safely give the protein up to 0.8 gram per kg per day if the proteinuria is there. And if the patient is on dialysis, 1 gram per kg per day can be given if the protein is especially from the plant origin. So it is very, very important to emphasize on this. Most of our patients are already taking low protein intake, and as many of the speakers in the CardAppCon has also emphasized that since our patients are already taking low protein intake, there is no point in further reducing the protein intake in our this subgroup of patients. And this is also important that if you're yes, Dr. V.V. Ram, you want to say something in this area?
Good morning, sir. Can I say something?
Yes, definitely. Go ahead.
Good morning, sir. I'm Sushma Tiwari, a registered dietitian whom you had invited at the CardAppCon. And congratulations, Dr. Nupur, sir. And sir, that you people are doing it so beautiful, this kind of interaction and exchange of ideas. In relation to protein, I wanted to say, sir, that not only the quantity, but even more important is the quality of protein.
Yeah.
Okay. Even more important is the quality of protein. And secondly, we need to kind of have it more, you need to divide it in equal amounts throughout the day. So for example, if I may say, we have 4 meals in a day: breakfast, lunch, evening snack, and dinner. So maybe if it is a 60-gram protein intake, we divide it into 15 grams per meal. So what we see is कि दाल लेते हैं, बहुत लोग दही या दूध नहीं पी पाते, intolerant होते हैं lactose के with the age. So we need to work on the cereal pulse, cereal milk kind of combination, or pulse milk combination. So those are little intricacies that not only the quantity, but more importantly, the quality of protein is of concern. And ऐसा नहीं कि एक बार इन्होंने खा लिया, समझो 30 ग्राम प्रोटीन एक मील में दिया, then the person gets bloated, you feel bloated, you can't digest that much protein. So hence we need to have it in less quantities, but with every meal. So this is what I wanted to say as far as protein is related, sir. Thank you.
Yes, very valid point. We take this point and we'll try to include this thing into the newsletter also, and your name will be displayed on that. And this is a very practical point, as our dietitians are also prescribing in the same form. And unfortunately, this is not being emphasized in our clinical practice, and this will lead to imbalance in the diet prescription, and eventually there will be problem in terms of postprandial excursion of the glucose.
Yes, sir. Thank you.
Dr. Rama Kumar, I think, want to say something.
Yes.
His hand is raised.
Thank you and congratulations for this. And I feel we need to address sarcopenia in type 2 diabetic patients. For this, it will cause insulin resistance, and diabetes control won't be there if there is less muscle mass. So this protein intake will definitely increase that along with exercise. I am promoting my patients protein intake more because it will give better blood sugar control, and at the same time, interestingly, if you give more protein, they will lose weight. That's an interesting thing. So you have to work on it and promote proteins for our diabetes. Thank you.
Okay, so point well taken. The sarcopenia will also improve, and as we all know, the sarcopenia is one of the important predictor of the diabetes complication, as well as the it will have an important impact on the diabetes management. Thank you, sir. So may I move to the next topic, or somebody else want to say something? Dr. Nikhil, or anybody else?
Dr. Nikhil, go ahead.
Good morning. Good morning, everyone. Good morning, Dr. Ashutosh. So, yeah, I just wanted to add one point, what Dr. Sushma Tiwari said about distributing the protein intake throughout the day. So most of the people usually focus on taking protein intake in breakfast. So what I have seen and what I have read is that if we take very high amount of protein in one meal only, then only a part of it will be absorbed and utilized by the body, and the rest of it will contribute to more unnecessary calories, and it can in fact result in weight gain and increase in cholesterol profile also.
Okay. Okay. So it's valid, and many people are utilizing high protein diet at the night time as a meal replacement therapy, and that is also one of the strategy in the early time restricted eating program, in which we can give meal replacement by protein predominant food in the night, and it will reduce the postprandial hyperglycemia. And due course of time, since most of our patients are in having the postprandial hyperglycemia at the night will continue for another 10 to 12 hours, and it will have an impact on the fasting as well as the HbA1c. So this is very, very important to emphasize the timing of the protein intake also, and I think this will benefit the physician as well as the dietitian which are practicing in the area of cardio-diabetes and renal patients. So
Sir, two things I wanted to say on what you just said and what Dr. Nikhil said. Firstly, he said that, more of protein at one meal may not be utilized completely. That is true for every nutrient. Body will take as much as you want, and then the rest will be stored. And again, too much of protein is not easily digested by us as human beings. So hence need to kind of stagger the protein intake. And secondly, aapne jo kaha ki bedtime protein intake is important to prevent the morning hyperglycemia. So earlier we used to, as dietitians, we used to, bedtime we used to give a glass of milk or some nuts, etc. But now the science says that it is not only protein, it is also carbohydrate, which is very important to ensure that the person does not get into hypoglycemia. So what I'm trying to say here is that meal replacement should be the last kind of alternative only when needed. आप bariatric surgery जा रहे हैं, you're morbidly obese, अगर आपके पास कोई alternative नहीं है, then, but otherwise it is very important that meal replacement should be the last form of therapy. And there are many ways in which you can improve protein. It doesn't have to be the expensive meat and fish and poultry or milk and milk products. अपना simple chana मूंगफली भी अच्छी है. Those type of things अगर भी हमने किया तो it is nice. And Dr. Ram sir had very well pointed that we are having the double burden of sarcopenic obesity. So sarcopenia is another very important thing that needs to be taken care of and addressed. So exercise again is very important. May not be, full aadha ghanta sabere, aadha ghanta sham. It could be as less as 10 minutes, 10 times in a day. So for people who can't walk because of their weight or because of any other conditions, because of age, they can have it. We can again stagger the exercises, provided they should know that you have to exercise in whichever capacity you can. Thank you, sir.
Okay. So point well taken. So let's move to the next topic. Next slide, please.
Okay. I think there are a few more people who have raised their hands. I see Vinod
So I advise them to type in the chat box and we will include their thought process. You have to just type a one-liner or two-liner message, and that will be elaborated and it will be accommodated in the newsletter. So if there is somebody else who want to speak, yes, hello, Dr. Vinod. Dr. Vinod, go ahead. We are listening. Dr. Vinod, please.
Nupur, unmute Dr. Vinod. Nupur, please unmute Dr. Vinod.
He has to himself unmute it. Sir, Vinod sir, can you unmute yourself?
Am I audible now?
Yes.
Yes.
So,
ahead,
very good morning and congratulations, Dr. Ashutosh sir, for this brilliant initiative. And as we have a distinguished gathering of not only diabetologists, endocrinologists, but great nutrition expert also. So my common question to everyone, I would like to learn from you, how does vegan diet help impact, how does it impact the progression of diabetic kidney disease? That is my humble question.
Yeah. It's very relevant question. Anybody wants to answer this question? Dr. Susma or somebody else?
Sir, should I? May I?
Yes, yes.
Please.
Go ahead.
Dr. Vinod, when we talk about veganism, so veganism is a more strict version of vegetarianism, as we know. In vegan diet, when you talk about diabetes relation, then vegan has more of proteins in it from the vegetarian sources. When you talk about your complex carbohydrates, complex sources like cereals, pulses, lentils, legumes, nuts, and oil seeds. So besides this, it also has a good amount of fiber, again from the vegetables and fruits, because these are some of the things that are advised in a vegan diet. Hence, it is said that vegan diets help in better control of blood sugars, but that may not be the only reason. It may also be your kind of medications or the kind of severity of the disease. In the same breath, it does not mean कि vegetarianism जो लोग दूध और दूध के products लेते हैं, their blood sugars are not well controlled. And again, people who are into when we call of vegetarianism, where people who eat egg are not in good control. So what is more important is the composition of the diet, how you plan it in different meals, and how does a person meet up to the requirements of exercise, stress, medicines, etc. So vegan is good for euglycemia or a better control of diabetes, but it is not the alternative.
I understand, but my question was specifically related to the impact of vegan diet on the progression of diabetic kidney disease. And for this, I would humbly give up for want of time. I would be sharing a very good review article, 2022 review article in the group. Okay, thank you so much.
Okay, thank you.
Thank you.
What Dr. Vinod was trying to say that the vegan diets have a very important role in the terms of reducing the inflammation in patients who are suffering from diabetic kidney disease, and it will decrease the progression of CKD also, and it will reduce the systolic blood pressure. I have shared one of the information containing the role of vegan diet in progression of CKD patient with 3-4 references, and we also include Dr. Vinod's suggestions also, and that will be accommodated in the newsletter. So with this, can I move to the next topic? Nupur?
Yes, sir.
So next slide, please.
Yeah, we have moved to next slide. You can.
So why we should consider early onset type 2 diabetes as a different disease and plan of management. There are 5 votes for this. This is a very new topic which is coming into the area of cardio-diabetes and renal patients. What the conventional teaching is, most of the physicians and the dietitian or whosoever, diabetic educators, whosoever involved in the clinical practice, they think that these are the young patients. First of all, the definition of the early onset type 2 diabetes means anybody who is coming to the clinic with the age less than 40 years. That is the definition. And this early onset type 2 diabetes can be further sub-classified into the 2 portions. One, the people who have presented with type 2 diabetes less than 19 years, and another group who is presenting with the 19 to 40 years. So these are the 2 subgroup. One, we can say that type 2 diabetes in young, the less than 19 year up to the 18 year, and the type 2 diabetes in adult, that we can say that from 19 years to the 40 years. These 2 subgroups are also little bit different, but as a whole group, if you consider the type 2 diabetes less than 40 years, they behave very differently. And the problem is that up to the 18 years, many of the patients being treated with the pediatrician or some of the clinical practitioners in their OPD. Most of the pediatrician and most of the physician who are treating these patients, they face some challenges, and most of the time they pay less attention to the fact that these patient has very accelerated progression of the complication, like retinopathy is very common, the nephropathy is common, and they have very rapid progression as compared to the population who are presenting with the type 2 diabetes more than 40 years. And because of this increased progression, they most of the time land up into the insulin within 5 years, and with 1 or multiple complication in 60% of the patients. So imagine the situation where the patient are developing complication of the diabetes within 10 years, the onset of the type 2 diabetes suppose occurring at the 14 years. So at the age of 24, he will be having 1 or 2 complication, and 60% of the population is like that. And to add to the complexity, the person whose age is less than 40, the statins are not being given to the patient according to the guideline. And even if you estimate the ASCVD risk prediction score, most of the time it will underestimate the risk because of the age less than 40 is one of the criteria, which is mostly very important. And these subgroup of patients, they are having increased risk of cardiac disease up to the 15-fold. So imagine a situation, a child who is the future of the country presenting to you in your clinic with diabetes duration around 10 years, the age of 24, 25, 26, and he's already having 1 or 2 complications. And still there is no protection given, only the insulin and metformin is the recommended therapy according to the NICE guideline, and other people are very hesitant in prescribing other glucose lowering therapy which has got cardiorenal protection. So my point is that these subgroup of patients are having different distinct pathophysiology. They have diagnostic challenges that most of the patients, they are requiring the genetic analysis for the MODY. Some of the patients are having LADA. So this type of expertise is needed to further segregate into the true type 2 diabetes mellitus in the young adult, and most of the facilities are not available in the remote area. And the blood pressure measurement is also a challenge in this subgroup of patients, and blood pressure measuring machine having standard cuff with these patients are not available. So many challenges are there. They suffer from the depression, and the female phenotype predominant patients are there in the early onset type 2 diabetes mellitus patients. So these are the patients who are predominantly female predominant type 2 diabetes patients, where statin will not work even if you prescribe them. And these subgroup of patients will have PCOD, the infertility. So these type of challenges are there, and you hardly have any drug to prevent the cardiovascular complications. So in this subgroup of patients, we need to have a different strategy countering all these cardiovascular risk factors, and restoring the fact that these subgroup of patients will have better cardiovascular outcome in terms of exercise reduction, exercise weight reduction, and the other innovative therapy in the nutraceutical, so that they will have less cardiovascular effect. The ezetimibe is very important in this subgroup of patients, as this can be prescribed and this will take care of their cardiac risk also. And the social support, multiple other factors, collaboration, and so with the team is very important. And we need to counsel these patients for their cardiovascular risk and treat aggressively. So I hope this early onset type 2 diabetes, once we will emphasize in our clinical newsletter, so that will help us in creating more awareness among the physician, diabetologists, cardiologists, nephrologists, and even ophthalmologists to screen for the complication as well as manage the disease. So we are going to have this in our newsletter. Anybody else wants to say something? Yes.
Yes, Dr. Ashutosh. I think awareness to the patient is also very important, because most of the female patients are not that much aware that in this early age they will proceed into the cardiovascular disease. So we should plan a program in which we can plan a awareness program for these female patients. This is very important, and I think this area is very neglected in our country.
Yes, Dr. Pallavi, and this is very important part, and our society is also taking some initiative in terms of protection of cardiac disease in the woman. And the Dr. Pallavi is soon going to launch some slogan, and we will have a collective day dedicated for this, and across India we can increase the awareness among these young adolescent girl or young adult or woman age less than 40 particularly, to have their to know their cardiovascular risk. Different strategies are there, even different risk scores are being designed for these subgroup of people, and we need to have a different strategy, because the classical strategy doesn't work in this subgroup of patient, and unfortunately this area is not being emphasized by the major society working in this area. So once we will take up this area, we will hope that there will be more and more awareness, and other society will also come forward in this area to join us and collaborate us. So I will also like to have opinion from the house. If they want to participate in this program, they can collaborate with us, and we will have a different set of meeting for that. So I think Dr. V.K. Jagnani wants to say something. Hello.
Dr. V.V. Ramkumar.
Dr. Jagnani, please. Hello. Hello.
Dr. Ashutosh, I don't see Dr. Jagnani.
Hello.
I think Dr.
If anybody else wants to say something, because we are open to you all, and we just learn from you. We want to have opinions and feedback from you people, so that we can accommodate the things. And if anybody else wants to say something or post something, yes, sir, go ahead. Dr. Vinod.
Dr. Vinod wants to say something. Nupur, please unmute Dr. Vinod.
Dr. V.V. Ramakumar, I think, wants to say something.
Yeah, can I add, Dr. Ashutosh, one thing I want to tell? Empagliflozin is approved for a younger age group. Now they say that we can give.
Hello.
Can you hear me?
Hello.
Yeah, we can. I think
the
sir is not.
slogan which was proposed by Dr. Pallavi is listen to her heart. So this is the slogan, and this is the initiative which our society is going to take in this area. Listen to her heart. This is very, very important, and very soon we will have a comprehensive patient awareness program. So with the permission of the other faculty, I just want to move to the next topic. Next topic, please, because we are running out of time, and already 30 minutes is there approximately. So next thing is estimation of total body fat in cardio diabetes renal patient. This is also very, very important area, as we all know that the total body fat percentage gives a very important tool to objectively put the goals of treatment of diabetes in our clinical practice, since the visceral adiposity is very, very important, and we can emphasize this to the patient that look, your total body fat is high, and because the total body fat is high, you must go for estimation of the visceral adiposity also, and there should be a tool which can directly measure the visceral adiposity. So there are equations, there are different imaging techniques, there are different biomarkers which are available in this area. The most important anthropometric measurement which can give you idea about the visceral adiposity is the waist circumference. So waist circumference is one of the important thing, and it is very easy to do in our clinical practice. So I request all the faculty members and all the person who are joining this area to spread the awareness for the measurement of the waist circumference and the neck circumference. In our clinic, which we are measuring routinely the anthropometric measurement in form of waist circumference, neck circumference, the waist hip ratio, and the sagittal abdominal diameter. So these are very, very important. And if you are incorporating these little tests, you can, yes, the neck circumference and waist circumference are very, very important. Apart from this, the sagittal abdominal diameter, the waist hip ratio, these are also very, very important. And if somebody is measuring all these parameters, it requires hardly any investment, and you can very well train your one of your clinical nurse in this area, and anthropometric measurement can be done. And believe me, if you set the target for the waist circumference, neck circumference to the patient, and you will discuss these things, it will help and motivate your patient regarding the diet and exercise program also, and it will have an impact, as waist circumference is invariably associated with the having a direct correlation with visceral adiposity. And there are also many techniques like DEXA, the CT, the MRI. So, but these are the investigation which are only meant for the most of the time the research purposes, and this has got some cost implication also. But as Dr. Pallavi is suggesting that nowadays the coronary artery calcification becoming very, very important, you can collaborate with the radiological center in your area to motivate them to go for the coronary calcium scoring in your patient, along with the visceral adiposity estimation with the help of CT scan. This will solve the both purposes, and you can keep a reasonable price like 3,000, 3,500 for this. And this will give a very good information, and it can be repeated once in a 5 year. So that is one thing which can be done in your patient, and it will have a good idea of the visceral adiposity as well as coronary calcium scoring system. And believe me, if you implement this, this can change your practice, and you can segregate your patient in terms of high risk to very high risk patient. And at our center, we are doing this, and this has got very good results also. Apart from this, if somebody is having practice in the multi-speciality hospital with the facility of the DEXA, they can also go for the DEXA scan also. So,
there are a few questions also. Like Dr. Sayyed is asking about can SGLT2 be used in diabetes?
yes. So we'll take questions also. You can put that.
So there are a few questions in the chat box.
Chat box also. Okay. So what is?
So we can take in the last.
Yes. So question and answer we'll take at the last, because we are running short of the time, and I think this is the area of total body fat we will include in the newsletter. Another part is Another part is how to minimize UTI in clinical practice tips. So this is very, very important, as SGLT2 inhibitor is one of the important drug in our clinical practice, and this has been used very commonly for the protection of the renal patient, and for the protection of the heart failure patient also. Recently, the trial containing the emphasizing the role of SGLT2 inhibitor in ASCVDs has also come into the EMPA trial has also come, and there are other evidences also building up. So what I just want to emphasize is there is no doubt that SGLT2 inhibitors are very important drug in our diabetes clinical practice in terms of cardiorenal protection, and in terms of the hospitalization for the heart failure and the kidney protection. The important thing is the UTI, which is hampering its use in our clinical practice. Most of the clinicians are very afraid of using the SGLT2 inhibitor who are having already having UTI or having recurrent UTI. I know one of my relative who was from the medical fraternity was very afraid of this drug being used in his father for the recurrent UTI. So these are the common apprehension, but the problem is if you look at these subgroup of patients who are having UTI, you can very well manage the things with the help of little bit education. And what are the things which you can do in your clinical practice to minimize the UTI? First of all, you must counsel your patient regarding the drug side effect that this can have UTI, and you have to maintain the personal hygiene, as well as if the patient is not having CHF or not having renal problem, you can also advise him to increase the water intake to reduce the UTI. Apart from this, if the person is taking less amount of glucose, then again the glucosuria will be less and there will be less chances of recurrent UTI. And if somebody is having very high blood glucose like 400 or 500 and multiple drugs along with insulin being used, you can defer the use of SGLT2 inhibitor for another 10 days, so that if the blood glucose comes down, then you start the SGLT2 inhibitor, the amount of glycosuria will be less and hence there will be less chance of UTI. You have to be very careful in the particularly the patient age 50 and female patient who are prone for the recurrent UTI. In this subgroup of patient, you can advise the recurrent UTI patient the fluconazole, and from day 1 to day 10 of the per month, 3 months can be one of the strategy to reduce the UTIs. And you can try the intermittent regime. You can try the once a week or twice a week regime also, and then gradually escalate the dose drug to make the patient more tolerant for the UTI. And you can always negotiate on that, and patient will have less UTI. And it is a myth that one your patient is having UTI, it will have again and again UTI. So my point is, if you want to improve the chances of this SGLT2 inhibitor to be there in the regime, you have to take measures to reduce the UTI. There can be debate that some of the SGLT2 inhibitor are more causing UTI as compared to other, but I think this is the class effect, and if you can try different SGLT2 inhibitor, that can also work. It also depends on your patient. And utilizing non-antibiotic therapy, like if you are using cranberry extract, or if the patient is admitted for 1 day for the bladder irrigation with the tap water, or you can give some pulsatile dosing of phosphomycin, or you can give some bladder irrigation technique. These are the few techniques with the help of which the UTI can be prevented. And by doing practicing all these things, you can actually prevent recurrent UTI in your patient. So anybody wants to say something, because this is a very important area and we are facing this problem day in and day out. So this we are going to address in our clinical practice newsletter, GuideUp Gen.
So Dr. Ashutosh, I think initially everyone was not starting this drug because of the fear of UTI, but nowadays we are using this drug in day and day out, and there is no problem of UTI, and UTI is not that much problematic to start this medicine. So now I think everybody has learned to tackle the UTI with this SGLT2 inhibitor.
Doctor, yeah, okay. Next slide. Next slide.
Yeah, we are at next slide, sir.
Yeah. No. I have already discussed the clinical pulse in that area, and we will accommodate that. And if somebody else wants to have their opinion, they can just type it on the chat box, or they can raise their hand to share their opinion. Okay. Dr. Vinod, you want to say something? Just go ahead, unmute yourself and share your opinion.
Yeah, sir. I think I have humbly shared
Dr.
some.
Vinod?
Yeah, can I be heard? I have unmuted myself.
Yes, we can hear you, sir.
Yeah, so nothing to add, but I have just humbly shared some very good, one very old and
Dr. Vinod,
at least-
go ahead. We are listening.
Yeah, so I have just
We are
shared
listening, sir.
Yeah, sir. Am I audible?
Unfortunately,
Yes, you are audible. I think Dr. Ashutosh is not able to hear.
Yeah, so I just wanted to, Madam Nupur, Madam, just humbly tell that I have shared some useful articles for our group in the chat box. Okay, one is a very old one, classic one, 1984. Remaining are all contemporary in the 22-23, 2022-23 articles. So those who are interested, they are free to download. They can go through. And they are all related to the topics being discussed. Thank you so much.
Sure. Thank you. Thank you for your insights.
another topic which is being included in our newsletter is the blood glucose control in the intensive care unit. Earlier, it was a concept that there should be tight glycemic control in the ICU setting, and if you are having a tight glycemic control, that is the blood glucose ranging from the 110 to 180, then there will be a benefit. So nowadays there are some new development which has occurring in this area. One is the type 2 diabetes patient are different. The diabetic patient are different than the non-diabetic patient. For the non-diabetic patient who are having stress-induced hyperglycemia, there you can go for more strict control as compared to the non-diabetic patient. The consensus is you can target 80 to 140 for the non-diabetic patient. But for the diabetic patient, better to keep the blood glucose control around 140 to 180. That is the new development which has taken place in this area, and we need to individualize the patient regarding this. Like if the patient is having more glycemic variability, autonomic dysfunction, the cardiac problem, the renal problem, accordingly you can set the individualized target for that particular patient. And the main aim is to avoid hypoglycemia, to have the decremental effect in case of diabetes. So I think this can be included in the newsletter. And if somebody wants to say something in this area, we will have a discussion on this. The question is open to the house for the
don't think that we have anyone speaking. So shall I move to next slide?
Yes. Move to the next slide because we are very little time left, only 7 minutes. And we have to finish it off, and we have to take question answer also. There are very important question which has been raised in the chat box. Yes, next slide, please. Nupur, I'm not saying, yeah. So another thing is the GI as a therapeutic strategy for the diabetes prevention. This has a new thing which has come up in this area, and basically the GI, the gastrointestinal tract can be one of the important area potential therapeutic target. And many people say that diabetes is a gut disease because you can modify the gut microbiota metabolism, and modulation can be there, and this a new healthy type of gut microbiota can have an impact on cardiodiabetes, renal thing. And we have lots of topic in this area, and lots of discussion in the CardAPCon also. So insulin resistance can be minimized if you can modify the gut microbiome with the help of diet, exercise, the stress reduction, and other thing. Nutraceuticals are very, very important in this area. This thing can be accommodated, and the incretin modulation can also help in this area. So different type of therapy which can have an impact on gut hormone regulation and nutrient sensing and absorption pathway can also be influenced on this. So intestinal inflammation can also be targeted, as we have already discussed the different strategies to tackle the intestinal inflammation by increasing the gut barrier and the mucin producing bacteria, and the duodenal mucosal resurfacing can also be one of the important thing in this area. Hello, am I audible?
Yes, you
Am
are.
I audible?
Yes, Dr. Ashutosh, we can hear.
Am I audible? Nupur,
Yes,
can you
even
hear me? Yes, yes. I think Vinod, Dr. Vinod wants to say something. Hello.
Dr. Vinod, go ahead.
Okay, okay. So I think this is very, very important area, and this area can be accommodated in our newsletter. There is no problem in that. And if there is any suggestion, please type it into the chat box and give reference also, and we'll try to search on that, research the all review related to that, and that can be accommodated in the newsletter. Next, the characteristic of early onset type 2 diabetes mellitus, the definition and future trend I have already discussed. So I think this can be skipped. Already
Okay,
I have.
this is the last topic, Dr. Ashutosh, so we can move to Q&A session then.
Yes, yes, definitely. There are two more things which has been put by the Dr. Pallavi initially in the chat box. One is the role of colchicine in the treatment of the secondary prevention of the coronary artery disease. This is also a very, very important area. And now there are data coming up that long-term use of low dose colchicine can be also be one of the very important strategy, and it has hardly any side effects with the low dose colchicine. So I request that low dose colchicine can be incorporated in our clinical practice to all the doctors who are practicing in this area with some precaution, and I think it will have an impact on low grade inflammation and neutrophil eosinophilic trap and the neutrophil recruitment also. So this is one thing which is coming up, and we should utilize this strategy to give the benefit to our patients who are having very high risk. Nowadays we all know that there are patients who are having very high risk group also, which requires multiple therapy like high dose statin, ezetimibe, and sometimes we have to give the bempedoic acid and PCSK9 also in some group of patient. So in this type of patient where we are focusing on mainly on the secondary prevention of the disease, this is very, very important, and low dose colchicine can also be used in our clinical practice, and this should be emphasized, and so that more and more people are aware of this fact, and this is now available also in the market, and we can utilize in our clinical practice. Dr. Pallavi has raised this very important topic, and if somebody wants to say something, Dr. Pallavi or anybody else, any suggestion or comment in this part? If there are any suggestion, you can put it into the chat box also. Another topic which was important in this regard was the role of coronary calcification scoring in the particularly the young patient, where the cardiac risk is high, and the conventional tools has failed to predict the cardiovascular disease in this subgroup of patients. So we should utilize coronary calcification scoring in this subgroup of patients to modify our treatment in this area. So this is also one of the thing which has been included in the newsletter, and very soon we will have uh, a rough draft being posted in the group, and uh, uh, we will like to have your opinion in this regard. Coming to the question and answer, I'm not able to see the chat box. Yes.
I can
So
read
there,
it through.
yeah. So please, Nupur, please.
Okay, one question from BK Jagnani sir. What is the place of trigonelline in management of metabolic disorder, including diabetes, loss of libido, and erectile dysfunction?
Trigonelline. So this is something I am not aware of, Dr. Jagnani. I have to research for this. Unfortunately, I don't know the answer, and I will like to have opinion from the house, or give me some time so that I can research it on this area, and I will post the answer into the faculty group. Okay.
In simple words, it is fenugreek seeds.
Acha, fenugreek seed. Okay. So there is some role, but I need some time to read little bit more in this area, and I will post a scientific answer along with the reference. Is that
Noted.
okay? Okay.
We don't have any more questions, Dr. Ashutosh.
No, I
it's
think
come.
there was some question on the low dose of SGLT2, Dr. Jagnani. Hello? I think there was
Yes, sir. Yeah. Tell me.
Yeah. So there is one study using AMPA 2.5 milligram in type 1 diabetes patient as a low dose drug. But in that, you have to be very cautious about the insulin dosing. Another thing, don't reduce the dose of insulin. And patient, the subgroup of patients who are gaining weight with the therapy, and a person who are having more proteinuria and they are progressing towards the diabetic nephropathy. So in this subgroup of patient, uh, this drug is very helpful if the person is having fluctuation of blood glucose, and uh, uh, the charting shows that the postprandial blood glucose are very high. So in that situation also you can use this drug to decrease the glycemic fluctuation. So
If possible, can we share this study with me or in the group so that I can
we can include this study in the newsletter also, and your name will be accommodated
because
on that also.
I have one patient in which I am doing this and I've got good results. So I
Yeah.
just looking for some scientific reference. Thank you so much for giving that. Kindly share the reference.
Okay. And if possible, share us the profile of the patient so that we can highlight this case as one of the interesting case in this area.
Sure. I'll make a paper and send it to you.
Thank you, Dr. V.K. Jagnani.
Fine.
Thank you, Dr. Jagnani.
Any other question? Any other?
No, in the chat, we don't have. Anyone has any other question?
I think there was a question pertaining to the pre-diabetes also.
No, there was a question. Any studies on SGLT2I in type 1 diabetes management? Maybe
Yes.
a low dose.
Role
So
of SGLT2 inhibitor in pre-diabetes.
Yes. The question is, any studies on SGLT2I in type 1 diabetes management, maybe low dose 5 mg EMPA with
No,
sufficient
that we
water?
have already discussed.
We already
SGLT2
covered, yes.
inhibitor in the pre-diabetes.
Can SGLT2 be used in pre-diabetes? That also we covered, right?
The SGLT2 inhibitor has potentially shown the benefit in delaying the progression of pre-diabetes to the overt pre-diabetes. So there are systemic review and meta-analysis in this area also. And DAPA and AMPA has been evaluated in this. So these are the drug which can be used in both pre-diabetes and pre-hypertension also. So this is very, very important point, and this, I think this can be included in our newsletter also. Okay.
Okay.
But this is a new area which is developing, and we need a large randomized control trial to have a robust evidence. And then we have a um, uh, opinion and definite answer about this. But till now, it can be used in a patient of pre-diabetes who requires weight loss, whose cardio-diabetes renal risk is very high, or a female who is having PCOD. So if this subgroup of patient, if the HSCRP is high, if the magic score for the heart failure is high, so all these subgroup of patient, this can be used as one drug can solve many problems. The SGLT2 inhibitors are also approved for the non-diabetic population with the CKD and non-diabetic population of the CHF. So that suffices the need of the patient. If there is multiple indication, then in that scenario you can judge the risk benefit ratio, and yes, SGLT2 inhibitor can be given in some subgroup of patient, not all, in pre-diabetes also. So thank you very much from the my side. Nupur, go
Yeah,
ahead.
thank you, Dr. Ashutosh. So, I don't see many people. I think we have still some. So this is a link where we have CardioCon 2024, all the photos shared. This I will share in the group also. So everyone, whoever has the link, they will be able to access the photos. There are around 650 photos, and that is why we have a drive link. Apart from this, we also have our YouTube channel launched, and we have uploaded a lot of videos of day 1, and day 2 and day 3 is also in progress. So in next couple of days, you will have access to YouTube channel where you can go through the conference videos, individual lectures. So that link also I will share, and I will request everyone to subscribe to our YouTube channel. So you keep getting updates regarding our new uploads. So I will be uploading even this meeting on the YouTube channel in case anyone wants to go through what happened during the meeting. They will be able to see it. Apart from this, we have our society membership. So these are 8 doctors who are our new members in the society. Congratulations to them, and they are lifetime members. If anyone else want to register for membership, this is our Gmail ID, cardepconsociety@gmail.com. We have our YouTube channel, LinkedIn community group, and Facebook groups. I would request everyone to join them. I will share the link in the group. For society membership, we have fees of 3,500, and we need all these details like your MCI registration number, state of registration, what is your personal details like first name, last name, gender, designation, what are your specialty, your mobile number and email. So we can send you the updates on those provided details like email ID and phone number. We will keep sharing the details. That's all. Thank you so much. It was a wonderful meeting and very insightful topics were discussed. Thank you everyone for joining. Thanks, Dr. Ashutosh, for covering it. Thank you, Dr. Pallavi.
Thank you,
Thank you, Nupur. Thank you.
Thank you,
very much.
Nupur, for organizing these meeting and keeping all those contact into the place, and having all of us in one particular platform. Thanks everybody who have joined this meeting, and we'll meet again in last week of Saturday, last Saturday of the month. So that is scheduled every month, and in meantime we will finalize the content of the newsletter as well as proceeding for the Thank you.